Hello, everyone, and thank you so much for joining us today. My name is Nicole Lamberson, and I'm a physician assistant, and I'm also a patient that took and withdrew from psychiatric medication. I work doing outreach for the Medicating Normal team to help spread the word about the film and to facilitate important conversations like this one. I'm so excited today to bring you our fourth live interview with one of the wonderful individuals that we have met along the journey of making and screening our film, Medicating Normal. Before we get to our guest, I want to announce that we have built a Medicating Normal store containing t-shirts and stickers. Unfortunately, they can only ship to the United States. With coronavirus and everything else, we could not find a way to make it an international store. That said, the store will only be available for 5 more days, and we need to sell only 25 more t-shirts to get to our goal of 100 shirts before the batch goes to print in 5 days. So if you're interested in purchasing a shirt, you can go to medicatingnormal.com/store. The store is part of our fall fundraising drive. We have quite a lot of expenses right now, and it takes viewers and donors like you to get us through to distribution of the film. Some of our costs include translating the film into several languages for international screenings. We just got an inquiry today from New Zealand. Apparently, you cannot talk about methods of suicide. It's illegal to do that in New Zealand, so we're going to have to go through and edit some of our film to be able to show it in New Zealand, which costs money. We have to maintain our website, keep the YouTube channel going, outreach efforts, Zoom platform fees. It's much more costly behind the scenes than people appreciate. So please, if you can help, either by purchasing a sticker or a t-shirt or giving a bigger donation, we welcome your support. Again, our store is medicatingnormal.com/store. And to donate, you can go to medicatingnormal.com/donate. All right, so our guest today is Mark Horowitz. Let's see, I just want to make sure that I'm recording this. Here we go. Okay, our guest today is Mark Horowitz. Dr. Mark Horowitz is a training psychiatrist and a researcher who has a Ph.D. from King's College London on the neurobiology of depression and the action of antidepressants. He also, for many years, took the drugs he prescribed. When he tried to come off them, he had a quick and sharp education into the world of withdrawal and the lack of knowledge in the medical field about this topic. Since then, he has tried to bring more awareness to the topic of safe de-prescribing of psychotropic drugs, academic work, including articles published on how to safely taper antidepressants and antipsychotics, and work with the Royal College of Psychiatrists in the UK on developing their guidance for patients stopping antidepressants. He's currently the clinical research fellow on the RADAR trial in London, looking at the effect of gradually tapering people with schizophrenia off their antipsychotics. So welcome, Mark. Thank you for joining us today.
Very happy to be here. Thanks for inviting me.
Thank you very much. So I'm going to start the conversation off with a few questions that we at the film have, and then we're going to open it up to our audience who is watching us live on Facebook, and then they can ask some questions. Before we start, I just want to say this conversation should not be taken as medical advice or encouragement for anyone listening to stop your prescribed psychiatric medication. All psychiatric medication needs to be tapered very gradually, carefully, and slowly. We never advise abrupt withdrawal. So, Mark, let's start with a little more about you. Can you tell us what made you interested in psychiatry to begin with? What is a training psychiatrist? For those who don't know, and in the past or currently, do you treat patients at all? Or yeah, tell us about that.
Well, why am I interested in psychiatry? I come from a neurotic Jewish family, probably as portrayed on Woody Allen films, people screaming and crying and doing all sorts of, reacting to life in all sorts of strong ways. So I read Freud when I was a teenager, and I basically went to medical school to become a psychiatrist. You know, I had ideas that it was a place that melded together science and humanities, and I thought that I could be a very humanistic doctor who would help people with the latest scientific tools and understanding, as well as with some kind of humane touch. That was my intention, and also a lot of my family is a very medical family. My mother's a pharmacist, so it was a very pharmaceutically inclined family. So over the years, probably of the normal ups and downs in life, we all at different points were on medication, psychiatric medication, for probably everyday stresses, but we had personal contact with it, and that also inclined me to an interest in psychiatry. So I'm a training psychiatrist. It means that I am doing a training program. I've actually made my life very complicated for myself by doing several academic degrees along the way. So I started my training in Australia. You go through a several years training program where you do different rotations in different parts of a psychiatric hospital and outpatient clinics. For two reasons, both of which are relevant to this conversation, I became very interested in what was actually happening in the brain. I thought that's where the answers lay. And so I did a PhD basically in the neurobiology of depression and antidepressants. How do they work? And my idea then, after reading books like Peter Kramer's Against Depression, was that the answers to depression and anxiety would be found in the brain. And I got very interested in stress hormones and inflammation, and why antidepressants. My idea about them then was that they were reasonably effective, but they weren't good for everybody. That was my personal experience, being on antidepressants since I was 21. I sort of had this idea, well, they're probably helping me a little bit, but I'm not sure to what extent, and they clearly could be better. And so with those sort of ideas, I went to do a PhD. And I've been a little bit back and forth between Australia and England. And I have come back to England to do research now. Now, the other reason I did a PhD was because I was extremely tired. So I actually had a lot of trouble with my work as a doctor because I became very tired and I had significant problems with memory and concentration. And it got to the point where it was making it very hard for me to work. I went down to part-time work, and I also thought about quitting work and even applying for disability because I was severely impaired. I was sleeping during the day. I was on increasing amounts of medication for the diagnosis I was given, which was narcolepsy. So I was told that the tiredness that I was experiencing and the memory and concentration problems that I had were due to narcolepsy. And in part, I thought doing academic work would make life easier for someone that was having trouble with clinical work. And so that's why I did my PhD. Do I see patients? Yes, I've seen many patients. I've worked in inpatient wards as a psychiatrist. I've worked in outpatient clinics. I've worked in lots of different, over the years, I've worked in lots of different parts of the psychiatric system. I guess this all sort of comes to when I changed my ideas about psychiatry. Because I guess I'm someone who had, I guess, fairly conventional, or what I would have described as biopsychosocial views. I thought that there was biological issues in psychiatric illness. I thought people's genes and their brain neurochemistry played a role. I thought there were psychological issues. I thought there was social issues, like I think most psychiatrists think, and probably like most psychiatrists act in real life. A lot of what it was biological, because that's what happens when you're seeing people quickly. I had the same ideas as most psychiatrists, that the drugs we're using are fairly effective, that there's different degrees of safety issues with them, but that overall the drugs are more beneficial than harming. And that's what I had been taught for many years. I was, like lots of other trained psychiatrists, extremely busy and tired and overworked. And so I didn't do any reading beyond the curriculum. I memorized the things that I was taught, and I'm a very good exam monkey. I've been doing exams for many years. I did very well at my exams, being regurgitating essentially what I had been taught. Make that, but so that was I had asked at different points along the way to different doctors, is it possible that the antidepressant I've been on since I was 21 is the cause of my tiredness? Because I had encountered papers that said that antidepressants can disrupt sleep and maybe that they can cause tiredness. And I was always reassured, no, you're on low dose. It couldn't be that, it's your narcolepsy. If anything, the antidepressants are helping you. And again, although I sometimes brought in academic papers to see doctors, essentially I thought these people are more experienced than I am, and I took their views and stopped thinking about it. I had a little bit of a moment of change when I, at the end of my PhD, read about antidepressant withdrawal symptoms on an online blog. And it was a blog called The Mental Elf that is directed at professionals. And I was flabbergasted by it, I've got to say. It went through all the different symptoms you could have coming off antidepressants: brain zaps, headache, depression, poor sleep. I had never, ever heard of antidepressant withdrawal symptoms in my life before. It was the first time I read about it. And at first I thought, this can't be right. I mean, how could antidepressants are completely safe? They're mild drugs. It's like paracetamol, or what you call Tylenol in America, something you could hand out to kids. I treated it pretty, let's say I was probably a little bit more conservative than other doctors, and I often thought, is this really a medical problem? But I was fairly used to giving out antidepressants and not thinking they meant very much in terms of side effects. Reading this article gave me real cause for pause. And my first thought was, drugs that cause withdrawal symptoms are not good drugs for you. I knew that opioids and benzodiazepines cause withdrawal, and withdrawal means that you're becoming tolerant to a medication. Medications that you become tolerant to end up not doing anything and generally cause more trouble than good. And so the first thing I thought was, I don't think I should be on medication that causes withdrawal symptoms. And so being the geek that I am, I went to read all the studies about how to come off antidepressants. And they basically all said that you can come off over 2 to 4 weeks, you can halve your dose and then stop it. And then, because I was already used to looking at patient forums online, because I looked up drugs that I was prescribed for depression and for narcolepsy, I already had the idea that patients are generally cleverer than doctors, because every time a doctor was unsure whether there was a side effect, I'd go online and patients would say, yep, I've had the side effect, and so has 15 people that I know. So I already had a degree of respect for what patients were talking about. I realized they worked things out pretty cleverly, because you are forced to become an expert when you're taking these drugs and the side effects. So I looked up withdrawal effects online, and I saw a completely different account of what was happening than what I saw in the academic literature. I saw people saying that they had incredible trouble coming off their drugs. It took them months or years. And the other thing I noticed was that a lot of people were saying that whilst they were on these drugs, they felt tired, they had concentration problems, they had memory problems. And I started to think, oh my gosh, I've been on drugs that have been causing the troubles that I have been, going from doctor to doctor about. And is it possible that it's been an own goal that I've been taking? It's the drugs that I've been taking that have been causing it. And I soon realized that I'd been diagnosed with narcolepsy only a few months after starting my antidepressants. So I sort of had this moment, like at the end of The Usual Suspects, where he looks at the board and realizes that it's all been a little bit of a story. And I decided to come off the medication. I decided that I would come off over a few months. And what ended up happening was a total disaster. I became incredibly anxious. I couldn't sleep. I had panic attacks for the first time in my life. I was in fact actively suicidal for the first time in my life. You know, my baseline, I am a neurotic, worrying, Woody Allen type of character. But the things that I experienced when I came off these drugs too quickly were of a completely different nature to my usual level of anxiety. And so in my mind, there was no doubt that it was withdrawal symptoms. However, I was in such a bad way. I ended up moving back from London, basically back home to Sydney, Australia, to be close to family because I just was beside myself. I ended up getting back on the drugs and actually even took more drugs in order to stabilize after going through that experience. I actually put it to the side for a couple of years because it was such a frightening experience. I actually ended up seeing more doctors and getting more medications, so I ended up on several medications. I actually ended up on 4 medications. I think at some point I'd been on 6 at the same time and cycled through 30 different drugs, which I now realize is a very common trajectory in psychiatry. I got to a point where I was not working well, and I thought about quitting, and I went for it. I basically took leave from work because I was in such a bad state. And while I was on leave, I decided that I would try coming off medication again. I had this idea. Again, I remember what I'd read that I thought maybe the medication is behind what I'm experiencing. And I again went and read all the literature and looked more closely at peer support websites, places like Surviving Antidepressants, places like the Withdrawal Project. And I realized that I'd gone too fast. I'd done it in about 4 months before, and I was going to do it a lot slower. And so I did 2 things. One, I started coming off my medication. And within a few months, I sort of had the astounding experience of feeling less tired, feeling like my memory was improved, and being able to concentrate in a way, not like I had many years ago, but better than I had for many years. And it was such an astounding experience. I felt overjoyed that I found a way to get my mind back, because for many years I just thought, I used to be a fairly clever person with a good memory, but that had just faded away, and I just got used to being, almost the dunce in the class, basically. So to get that back was joyful, and I guess then all the regret and I thought I've wasted so many years experiencing these effects from medication. And the second thing I did was I tried to write an article about how to come off these medications according to the kind of principles that I'd learned from peer support websites. And that was an article that went on to be published in Atlantic Psychiatry, that had quite a lot of influence in England, in the United Kingdom, in influencing doctors to think about taking their patients off medication more slowly. I'm not sure it had much influence in the US. Sorry, that was a very long and discursive answer to 3 short questions that I gave, but
yeah,
hopefully that's of interest.
Yeah. It's funny, you and I have talked a little bit about our stories, and I have medical training too, and just the similarities and things that you just explained that I experienced in my own situation taking medication. I remember, a lot of things maybe you can say it's true in your situation or not, but hindsight in this is so enlightening. I didn't think of things at the time, but I remember taking antidepressants, and I had a roommate that said to me, you sleep more than anyone I've ever met. And I just kind of blew it off and thought, well, my dad's a physician and he takes naps all the time. So this isn't so weird. But in hindsight, I slept a lot, way more than the normal average person. I didn't get diagnosed with narcolepsy, but I'm sure, it was just similar adverse drug effects like what you were explaining in your story. And I have medical training like you. I had never heard of any of these withdrawal effects before. I didn't suspect it in my own self. And, I think my training sort of made me like buy into the drugs a little bit more. Do you think having medical training and going through what you went through in school made you think that these were good and beneficial and helpful?
Definitely, I identify a lot of things that you're saying. I think number one, we all exist in a medicalized world. Everyone, especially in the US, there's ads on TV for drugs. But in my world in Australia, where there's not ads for drugs on TV, I definitely existed in a medicalized family. My mother was someone, she's a pharmacist. We have a floor-to-ceiling cupboard in our kitchen that's full of medications, because for every ailment, there's a medical solution. So I definitely grew up, my mother's pharmacy journals, sort of lie on the ground, around her office. So it's definitely a place where drugs are normal. And I think that's part of why basically everyone in my family's ended up on some sort of psychiatric drug. Yeah. It was also normalized. I think the other thing is for doctors, and probably for psychiatrists in particular, it's normalized to give out the drugs. So I think a lot of psychiatrists I know are on medication. And I think that's because they're used to it. You hear the story, you tell patients a lot, take these drugs, it'll make life easier, it's a crutch, it'll get you through a tough spot. And eventually you listen to that yourself. Although some studies say that psychiatrists would prefer to wait and see, or see a therapist for themselves rather than give medication. So there's probably a little bit of a double standard. But definitely in my mind, I was so used to giving out these medications that became normalized. And I also had a rose-tinted view of medications, which comes, I think that's systematic now that I see it, because, for example, I've been to hundreds of lectures on psychiatry and neuroscience and pharmacology, and I have never, ever had a lecture on withdrawal symptoms from medication. It's been mentioned about benzodiazepines and opioids, but taking patients off medications, I've never had a lecture on that. I like to say the first lecture that I ever heard about taking people off medications was one that I gave. So that's just not a part of the curriculum. Withdrawal effects, not a part of the curriculum. Side effects are mentioned, but it's always in the context of these drugs are effective and very useful, and the side effects are annoying. Even the phrase side effects is, of course, a euphemism. I mean, there's not really great effects and side effects, there's just effects. But the focus of all studies is on the change in mood scores or anxiety scores in the short term. There are not long-term studies looking at side effects. And so the literature is biased towards short-term positive effects. Side effects are minimized, and that's amplified by your professors in the teaching. And also when you get into practice with patients, there is pressure. You know that the drugs are good for people. That's what you've been taught. You don't want to ring off a whole list of side effects that's going to deter patients. You think it's the right thing for them to do. So you're not doing it to be, you're not doing it to harm them. You're doing it because you think it's the right thing, and you don't want to put them off. So probably you minimize informed consent, and you maximize what you think is better for the patient. And you think you're doing them a favor. That's certainly what I thought. I certainly didn't mean anybody harm. My intentions, in going to psychiatry was to do good for people. I wanted to solve my problems. I wanted to solve my family's problems, and I wanted to solve the people I saw. That was my intention. I can see in retrospect, that I may not have been doing what I set out to do because I was ignorant, is the way that I see it. I was taught, a non-evidence-based rosy view of these medications. I didn't understand that the evidence was only short-term. I didn't appreciate that the adverse effects could easily outweigh the positive effects, but the positive effects were generally minor. So all this insight has come to me very late. So I do often worry, what have I done to some of the patients that I've seen? And I certainly discuss drugs in a very different way these days. And sorry, the last point is attributing side effects or adverse effects to the drugs. Because I was constantly told, I was reassured by people, no, that wasn't in my mind. I also kind of thought, look, when I started taking the antidepressants, they did make me feel a bit funny, a bit dizzy. I sort of thought, well, that's the price of admission. That's what happens. And so I did have a vague sense that some of these things were side effects, but I sort of thought, well, but this drug is important for me, so it doesn't matter so much. And I certainly wasn't aware of withdrawal effects. So it was all, as I said, a short, sharp education into what was really being caused by the drugs. And as I say, memory concentration, I was told that I had narcolepsy. I was also given a diagnosis of chronic fatigue syndrome along the way. I've heard lots of patients on antidepressants and other drugs get diagnoses like that. You keep on coming and saying you feel tired. Eventually someone will stick a label on your forehead. It happened to me. Yeah. And I think doctors and patients do not put the side effects together, in part because it's over such a long period. If you take an antibiotic and you feel sick tomorrow, it's obvious what's caused it. You take an antidepressant for years and you slowly feel more and more tired over years, or your memory goes off. People will say, well, maybe it's normal aging, maybe it's something else. Very hard to pick a medication that you're on for a long period of time and a chronic side effect and put those things together. And I think that's why I didn't make the connection, as well as, not being at the forefront of my mind.
Yeah. So you and I have talked some, and you've told me that you sort of, now that you're tapering off the medications, have to plan your life around dose reductions because the withdrawal symptoms affect your functioning. And can you tell us all about some of the symptoms you experienced tapering? And also, just in your answer previously, you said something about language, and I'm wondering if you think the word withdrawal sort of confuses medicine, or they have a, twisted sense of what it means to be in withdrawal when patients come and say, like, I'm in withdrawal, but it doesn't, it sort of minimizes the severity of, at least in my experience, what I felt. I mean, everybody conjures up an idea of withdrawal in their head, like people stop smoking cigarettes and they get withdrawal. But what I experienced coming off of psychiatric medication was so much more, I think, than what people experience stopping cigarettes and what we think of as withdrawal. So do you think the term is misleading?
Right. So I'll answer the second question first so I don't forget it. Yes, definitely. Doctors have in their mind withdrawal mostly from opioids. And they have the idea that withdrawal is something that lasts a week or two. That is firmly etched in their minds. Withdrawal from nicotine fits that. Withdrawal from caffeine fits that. So yes, every time a doctor in general uses the word withdrawal, they're thinking it lasts a few days. I think when the drug companies said that about antidepressants, that discontinuation symptoms are brief and self-limited over a week or two, which is this sentence that they stuck in the literature everywhere like a pharmaceutical meme, I think that doctors accepted that because it fits with their idea of what withdrawal looks like. And so the idea that withdrawal can last for months or years or possibly be permanent in some people is completely foreign to them. I mean, because they're drawing analogies to opioids and nicotine, but also because they have been systematically educated by drug companies using this line again and again. The drug companies, Eli Lilly had this meeting in 1996 to form a consensus panel to basically brand withdrawal symptoms of antidepressants, for example, as these mild, brief phenomenon. They said, let's call it discontinuation syndrome. Let's say it's brief and self-limiting. They had a few case studies to put together. They had a lot of fancy professors to put their name on it. And they basically put out this idea that antidepressant withdrawal is mild and brief. And that has stuck. That is in the guidelines in the UK, it's in the guidelines in the US. And so if doctors are looking up what does withdrawal mean, it means something brief and mild. And so when patients come in and say, I'm having awful symptoms, they're incredibly severe, they're lasting a long time, doctors conclude, well, this can't be withdrawal because withdrawal is brief and mild. And instead, they think this must be relapse. This must be the onset of some sort of new disorder like medically unexplained symptoms, which doesn't mean much, but that's what they think, or functional neurological disorder, because the concept in their mind of withdrawal is so different to what is actually experienced by clearly hundreds of thousands of patients. For me, withdrawal's been awful. I mean, it has at points, so I've been withdrawing now for the last 2 years plus, 2.5 years. I probably have another year to go. At points, it has been unbearable. I mean, it's made me, you know, I've felt when I've gone too fast, I've been incredibly down in the dumps. I can't concentrate. Everything, I have incredible depersonalization and derealization. Everything feels unreal. I feel awful. It's brought me to my knees at different points. Through a lot of trial and error, mostly error, I have worked out the sort of rate that I can reduce at, and with the help of a very obsessive spreadsheet, I've generally worked out that I can reduce by about 15% a month if nothing goes too wrong. Have a few days a month where I feel pretty rotten, and rotten means down in mood, not sleeping so brilliantly, feeling that sense of derealization, not being able to concentrate very well, generally feeling very fatigued. I take 3 days off work around a weekend every month to try to fit it in. It never works out brilliantly. I've always probably have a few days. It always lasts a few days longer than I hope. But I sort of in that way, and I'm very lucky to have a reasonably flexible academic job at the moment. If I had a busy clinical job or some of the jobs that I see other people doing, I'm not sure I could do it. I probably would have to quit. So I've had a very, very lucky experience with my work, but I can see how people can't do it, end up quitting and end up unemployed. That's something that frightens me in the future. So yes, that's how I've mostly managed it. And on those days when I feel terrible, I kind of cut myself a bit of slack. And I try to work around those days, try to get more done in 3 weeks to sort of make up for those days. So it's had a huge effect on my life. I mean, in lots of ways, my life has stopped because of it. I've kept working because the work that I do, very much fits into it. I'm writing about withdrawal. I'm helping people come off medication. It's had a huge effect on my social life. It's had a huge effect on my well-being. I feel like I'm living life in a sort of a half version at the moment.
Yeah, I can certainly relate to everything you just said for my experience as well. So I'm going to ask one more question for me, and then I think we'll go to some of the audience questions. I often think, of my own experience being a medical provider and medically trained, and how much trouble I had, even with that privilege of having that training and going to see colleagues with this problem and facing so much disbelief and difficulty finding a medical provider who understood what was happening to me and who would take me as a patient. And so I think, oh my gosh, if it's this hard for people who are medically trained, what is it like, for the lay person? And I'm wondering, in your experience, did you have trouble getting support from physicians that you saw? And what have your colleagues, since you've been so brave and transparent and come out and told your story publicly, which you did not have to do, but how have people in the medical profession, other psychiatrists, responded to that?
Well, the first part of the question, I mean, I acknowledge how privileged I am here. I've got medical training, I've got psychiatric training, I've got academic credentials. In this area, I couldn't be any better placed. I think that has got me through. So doctors I've asked for liquid versions of medication. I've been able to explain to them why. I've often had on my phone my academic paper. So I think that buys me a bit of credibility. Yeah. But I got to say, my heart breaks when I think about what people out there experience. I hear story after story of doctors disbelieving people, almost laughing in their face. And I'm really nervous. If my doctor stops prescribing a liquid version of the drug, that would cause huge trouble for me. So I sympathise with people in such a vulnerable position. I think that's the major thing that drives me, is that knowing I'm having an incredibly hard time and I'm in an incredibly privileged position. Other people are having an even harder time, and so in fact, I think I've got a little bit of an opportunity to help explain it to doctors. I feel again very privileged that I can put my suffering into something that's useful, that will be helpful to others, and very aware of other people having trouble. In terms of responses, it's been pretty mixed. I think most of my colleagues, they hear my story, and I think they they've had different. It's been interesting. Some of my friends have said, actually, you know what? I've seen patients have withdrawal effects. I think what you're saying makes more sense than what it's in what was in the textbooks. You're making a really good point. I will be more careful taking people off medications. And some people have come to me and asked, what's the best way to take people off medications? How do you get liquids? I think probably the most emblematic moment was I was invited to give a lecture at the Royal College of Psychiatrists, the equivalent of the American Psychiatric Association in the UK. I was to debate a psychiatrist in England who has been very skeptical of the withdrawal literature and has, in my view, sought to minimise it. And we had a debate at a national conference. And I presented the evidence for withdrawal. He presented the evidence saying that it's much less than people think it is. I think he's chosen rather selected studies. In any case, the response of the audience was very interesting. There was two generations in the audience. There was people who were in their 30s, the trainees or newly minted psychiatrists, and there were people in their 50s and 60s, the older group of psychiatrists. And the older group of psychiatrists basically stood up and said, I've never seen withdrawal. Every time I've seen it, it's been mild. I don't know what you're talking about. I don't know what all these studies are talking about. It's not what I see. And then younger psychiatrists stood up and said, how do I get patients to open up capsules and count beads? And can you order liquids for this particular antidepressant? So I think that's pretty, I think people who are younger, do not have formed ideas, haven't the 3 decades in their practice been told there's no such thing as withdrawal symptoms, because my first reply to the older doctors was, how can you see what you don't believe exists? If you don't believe withdrawal exists for more than 2 weeks, how could you ever have seen it? You must have diagnosed every case of withdrawal as relapse. I mean, it would be impossible to not do that. If you don't think that withdrawal is a thing, then when people come in complaining of anxiety and trouble sleeping, and you don't ask about brain zaps or dizziness, then of course you're going to diagnose relapse. I'm certain that I've done that in the past. So I do think there's a little bit of a generational divide. I also think that the key opinion leaders, the academic professors, have been essentially putting out a pro-drug message for many years, saying the drugs, generally exaggerating their efficacy, their usefulness, and underplaying their negative effects like withdrawal. So that is the soup within which psychiatrists swim. Very hard to see outside of that. And I think that also in a conversation with someone, at some point, a psychiatrist will say, so what am I going to do, not prescribe these drugs? Essentially, they're sort of saying, well, this information you're saying, it does sound a little bit important, but, that will completely upend my world. What else will I do? So I think they can very quickly see if the drugs cause withdrawal, that means that they're not as effective as they're said to be, because all the drugs studies are done based on stopping drugs in trials. They can very quickly see that it means a lot of their drugs, are much less effective than they're said to be, and that puts them in a very difficult position of what else would they do. So I think that any discussion about withdrawal effects leads to existential worries for a psychiatrist, and that I think that stops them thinking as clearly.
Right. So I think we'll move to some of the audience questions now. Mark, you've written some papers on antidepressants and antipsychotics, and those, if you're watching live on Facebook now, they'll be in the event description, and we can put them in the comment section now for you. If you're watching later and on YouTube, we'll put them in the YouTube video description. So this person, I think you have a paper coming out soon on benzodiazepines too, Mark, is that right?
No,
No.
it's a long and winding. So what you probably talk about. So there'll be a textbook that will have tapering advice in it. Papers. It's an exhausting process. It will take a bit longer.
Okay.
But yes, there will be next year.
So this person is wondering, since we're talking about, antidepressants, benzodiazepines, antipsychotics, is getting off gabapentin the same as getting off of those other drugs that we've talked about today?
Yes, I think there's much, although all these drugs have they affect different receptors. I think the principles are broadly the same. That all psychiatric drugs cause adaptation of your brain to the presence of the drug, which is experienced as tolerance. When you're tolerant to a drug and you stop it, you get withdrawal symptoms. That's true for, illicit drugs and psychiatric drugs. Gabapentin has a very similar mode of action to benzodiazepines or Z drugs or alcohol, to be honest. And so it also causes withdrawal symptoms. Gabapentin is probably slightly better than pregabalin. It's sort of buddy chemical, but yes, people do have all sorts of symptoms coming off gabapentin, like tiredness, you can get brain zaps, you can be dizzy, you can be anxious. And so again, this same sort of principles apply to that drug as do to other drugs, which is to come off at a small amount each month, generally by smaller and smaller amounts as you get down to lower doses, and to give yourself time in between to get used to the lower dose.
Mm-hmm. So the tapering really across the drug classes, in your experience and your research, you found it's pretty much all the same tapers and concepts. It's just the drug is different, or the availability, what form maybe the drug comes in. But the tapering process and the curve that you have to do is similar across all classes.
Yes. So I guess I'm drawing from a couple of different points here. One, yes, there's this curve, which is that the relationship between the dose of any drug and its effect on the brain is not a straight line, but rather a curve that flattens out, which means as you get down to lower and lower doses, each reduction you make has a bigger and bigger effect on the brain. That means that as you get down to lower doses, you need to make smaller and smaller reductions. There have not been many studies on tapering. So I am deriving what I'm saying from the experience of patients in generally online communities who talk about drugs like pregabalin or gabapentin, that it takes months or years to come off. For example, I'm aware there's a support group online for pregabalin that has 25,000 members in it. And they also follow the same kind of principles as people coming off benzodiazepines, which is something like reducing your dose by approximately 10% or a bit more each month based on the most recent dose. So it gets smaller and smaller as your dose gets smaller and smaller. There's a bit of individual variation. Some people can go a bit quicker, some people a bit slower, but in general, people say slower you go, the easier it is. That seems to me a general principle across all drug classes.
Okay. And you in that response, you spoke a lot about the evidence that you draw on comes from patient groups and that kind of thing. Just from my experience, even writing about these topics, for instance, I blogged at a place that's mainly for a medical audience. And every time I post a new writing about withdrawal, the same physician responds, well, that's anecdote, So how much, what is your response to that? And how much, it seems like you put value in the anecdote that you find online.
The response of that physician is trying to use a polite word, it's ridiculous. All of medicine is based on, it's based on a hierarchy of evidence. So, yes, a randomized controlled trial is a clearer, gives you clearer causality. You know what is causing what, and that is the best form of evidence. But it becomes, I would say, disingenuous when you start to dismiss hundreds of thousands of anecdotes. I always think, say to such doctors, if you heard that your exact mobile phone was, was set on fire, like some of these mobile phones were when they're plugged into certain plugs, how many such cases would you need to hear before you went to the shop and asked for a replacement? And the answer would be 3 cases, maybe 5 cases. But then they say, there's hundreds of thousands of cases of people having trouble coming off antidepressants, and they say, no, that's anecdote. To me, that is not an honest response. There are, first of all, there are randomized controlled trials very clearly showing there were withdrawal effects from antidepressants. Even if there weren't, once there's tens of thousands of cases, that is a strong signal, especially if in the case of a newer drug like pregabalin, there are not randomized controlled trials looking at withdrawal effects. If you have tens of thousands of people congregating online, then that is a strong signal that something is happening. And if someone is going to dismiss it with a one word, that's anecdote, that to me is not a thoughtful response to it. The correct response would be, that sounds like a problem, and maybe we need to do more studies to clarify it. But to dismiss it out of hand does not seem to me to be an honest response to it.
Well, and isn't it kind of hypocritical in that, I've always thought it's anecdote when a patient comes in and tells you I'm depressed or I feel anxious. No one is putting us through stringent testing. You just get a 10-minute consultation. They believe what you say and they prescribe you a medication based on that. But when you come in and say, I'm having withdrawal effects from stopping the medication, then all of a sudden it's anecdote and your word means nothing.
Yeah, I guess it's when it's
in some instances, yeah.
Yeah, I guess it's when it's either congruent with or incongruent with what you've been taught at medical school. They talk about, organisms have sensitive periods where stimuli mean more to them at different periods. And for doctors, that sensitive period is at medical school and soon afterwards, where your conceptual framework is set. And because lots of doctors have been told there's no such thing as withdrawal symptoms, or they're minimal, when someone comes in and says the diametric opposite, your tendency is to disbelieve them. So I put myself in the shoes of my colleagues. I think I would have very similar responses. Psychiatry is it's inherently subjective, like you're saying. The diagnosis of depression or anxiety, you're taking people's reports, so there's inherently a lack of objectivity to it. That's sort of part and parcel of the issues, because that's what you're dealing with. You're dealing with human suffering. I knew certain things, I thought I knew certain things, and if people contradicted those things, I would tend not to believe them. It didn't fit my frame. If people said the sky is green, I would have said that's not true. And I hadn't heard about withdrawal symptoms, so if people had come in and said I'm having all these awful symptoms, I would have thought they're a bit kooky, basically. So I have some sympathy for my colleagues who have a hard time getting their head around it, because it is new information, and there is this idea, well, you're dealing with neurotic patients, they're coming to see you for anxiety and depression, maybe they have more neurotic symptoms and this might fit in. And I probably would have been susceptible to that kind of thinking and that kind of interpretation. I have the privilege, or the exact opposite, of having experienced it firsthand, so I don't have any doubt in my mind. But I can understand that it is baffling to some colleagues. I would hope, though, that people are open-minded enough and receptive enough to what human beings are saying to them to change their mind when they hear enough. So I would that does lead to one practical piece of advice for people. I think people get exasperated if they're not listened to by their doctors, which I understand. If people can, I would go back to doctors and say, look, this is what's happened to me. I'm now tapering slowly, or I've had all these troubles. Say it to them calmly, so that at least if 3 or 4 people come into the same doctor, they're hearing this story and they may start to listen. I know it's not very fair to put that on patients who are already suffering, but I think that is one way. Doctors are not, they're not bad people. They're not trying to do harm. They are, but it is hard to get a new idea into your mind. So I think that's part of what's happening.
Well, in some cases, I think the medical providers are victims too. I mean, the pharmaceutical companies have put out deceptive information and that kind of thing. So yeah, I agree with what you're saying. This next person, it's sort of a personal account, but you can talk about it more in general terms. This person says, it's been months since I took fluoxetine in April. This was to mitigate withdrawal from paroxetine. I wound up having to raise my dose of paroxetine and haven't been able to shake the damage of either. I haven't been able to taper down. Are there medications that can reverse effects, including PSSD? My life feels not living. I'm so sorry for both of your pain as well.
Right. I mean, the awful, truthful answer is there is nothing that is known to improve withdrawal effects or PSSD. The only thing, in talking to people, in reading about it, the only thing that seems to work is time. People seem to get better over time. That is a terrible answer because people want a solution, and I can hear this person is suffering. But there does not seem to be a magic bullet to this. The only things that seem to work is waiting and stabilizing and then tapering more slowly if that's what you want to do.
And sometimes adding things can actually be, cause harm. They can disrupt the system even further, correct?
Yes, exactly. I've seen people who get into the most trouble are people who panic when they're having withdrawal symptoms and take a whole lot of other drugs, which is totally understandable because it's such a frightening experience and you want to do anything you can to stop it. But I think in general, adding more drugs causes more trouble. I would say the thing that works most routinely is some form of reinstatement in general. Increasing your dose back to where you were last, stable, or if need be, to go back to where you were at the beginning of the taper. I think those are the only things that I've seen that have tended to make people feel better.
Okay. So this person says, many of us that are polydrugged are on both antidepressants and benzodiazepines. Does Mark believe it's important to taper the benzo last, or is benzo withdrawal intolerance so bad that the benzo should be tapered first? Or is it different in every scenario?
I mean, again, I'm going to be spending a lot of time tonight saying I'm not sure. The answer is there's no research to say which one is better to come off first. I hear principles like do things that protect your sleep, which seems to imply coming off your benzo second. But I've heard different views. I don't think there's anything clear. I've also heard people say things like stop the drug that you think is causing you the most side effects. If you can't tell, I would suspect it doesn't really matter which one you do first, as long as you're doing both of them reasonably carefully. I know that there are people who do both drugs at the same time by very small amounts with the idea, well, it's affecting different receptors, so you can kind of balance it out rather than doing 10% of each one, maybe do 5% of both. But I would say to start with, you want to do one, so you get a good idea of what's happening. So you can see the pattern. You don't want to confuse yourself by doing 20 things at once. So I think, in short, the answer to that is I'm not sure.
Okay. And this person says, can you speak at all to the phenomenon of protracted withdrawal? I'm an admin in an online forum for SSRI tapering, and we see this often. Sometimes these folks have tapered quickly, and sometimes they've tapered slowly and carefully. Although I guess you'd have to define what slowly means. But the pattern is the same, several months off and then wham. I guess wham, they get hit with the
yes.
syndrome. And I haven't really seen any research on this, and I'm wondering what you may know.
So this is going to be the same, a repetitive answer. There is no research on it. I know nothing more than what I've read about from people. You know, a lot of the studies on withdrawal go for 2 weeks. That's what drug companies do. They take people off over 2 weeks and they measure symptoms for 2 weeks. That's what the majority of studies are about. The other studies are surveys of people on online forums. So to some degree, I'm just regurgitating what people already know. I don't know why that happens. I get the impression that people who take us slowly and more carefully do seem to get less trouble down the track. As Nicole says, maybe people's idea of slow and gradual is too quick, because I think for people who are on these drugs for decades, you know, I think 2 years is pretty quick. So I think some people certainly need to taper over years rather than months even. Why something would happen 7 months after or 9 months after being on drugs doesn't make sense to me, because it makes more sense. You've got receptors down regulated or upregulated. You remove the drug, the adaptation is revealed without the cover of the drug, and you get symptoms. And it takes however long it takes for those receptors to go back to normal for the symptoms to resolve. That's the explanation that makes the most sense to me. But there is no real research on it. People have all sorts of ideas that the autonomic system is dysregulated, that things downstream are dysregulated, all of which are possibilities, all of which haven't really been looked at. So if that could explain why something tips over the edge after a few months, perhaps, but it's all speculation.
Yeah. And I will say to that person who asked, this is just my experience. I did have, I was polydrugged and I was taken off very abruptly, medically advised to do so. And I experienced that. It was about 3 to 4 months into the cold turkey that the symptoms became horrific. And like you, Mark, having medical people in my family, it was the same response, was, what, this just doesn't make any sense. You know, why would you suddenly get worse at 3 to 4 months off? And of course, I mean, there was just no answer for it, but I have certainly encountered other people in the online support groups who report the same phenomenon. So hopefully one day we'll have more research and answers for these very difficult questions, but ones that those of us who are going through this really want answers to. And especially if we can find the answers to them and stop this, you know, from happening to other people. So I'm aware of the time. I think I'll ask you one more question to sort of wrap things up. Will you continue to do this work around research into tapering, withdrawal, prescribed psychiatric drug risks and harms? And I guess if you are going to go on to see more patients, can you be a psychiatrist that mainly focuses on de-prescribing? I don't think you'd have a shortage of patients at all. And then lastly, is there a place where people can follow your work?
Right. I say this from a position of great tiredness. Yes, I would like, you know, this is what I plan to dedicate my my career, if there is a career, to. You know, yes, you know, it's going to take me years to come off this. It affects friends and family of mine. You know, it's so yes, this is what I'll be focusing on. At the same time, I've got to go train in the conventional psychiatric system, which makes me nervous because there are certain conventions and rules and things. But yes, as you said, I would like to become a psychiatrist that takes people off their medication. That's where I'm aiming for. At the moment, probably a piece of good news for England, not for America, unfortunately, but there are de-prescribing clinics being set up in England, in the NHS, our National Health Service. So me and my boss, Joanna Moncrief, are setting up a clinic that is aimed to take people off their medication. That's all it'll do. In North London, there are 3 other places in England doing similar things. One of them has already started. We hope that will end up turning into a national system that will provide a service for people who want to come off their medication. I'm doing work on putting together guidelines such as we know so far for these drugs. We hope that there'll be more research that will look at the best way to do it for patients and answer some of the questions that you have put forward, although could take years. It's so many complicated questions, but I guess starting is the main thing. So you can follow me. I'm on Twitter. I think my handle is @Mark with a K Horo, MARKHORO. Often a lot of my ideas are strongly reacted to by other psychiatrists, let's say, strongly criticized. So whatever experience you're having in doctors' offices, I'm having it in real life with my colleagues often. Was there another question I didn't answer?
I don't think so, although somebody threw a good one here on the end. Does most research funding come from pharmaceutical companies, or if we're ever going to get funding to study these issues, like where would it come from, the money? Right.
So historically, yes, most of the published studies are done by drug companies. There is less and less investment in psychiatric drugs, I think, by drug companies. There's been a very big push recently for esketamine, a new drug in America, Spravato. There are a few other drugs in the pipeline, but I think there is less research from drug companies than there used to be. In Britain, in the UK, and in America, the government is a big funder of research. So we have the National Institutes of Health here, and you have the National Institute of Mental Health in America. I think part of the issue is that neuroscience is a very big part of the funding priority. So there is a medicalized view of mental illness, that we need to crack the genetic code, we need to do brain scans, we need to work out that, and that drugs are one of our best tools in the fight against mental illness. And so a lot of funding goes in that kind of frame, especially in America. In the UK, I would say there's broader ideas. There is social psychiatry. That is the idea that people's social circumstances play into their symptoms, and there's a lot of psychological research. There were 2 very big grants given to studies that are looking at taking people off medication or that kind of area. So one is the one that I'm working on. The radar study is people with schizophrenia being taken off antipsychotics. There's another study looking at open dialogue, basically a family talking therapy to manage people with a diagnosis of schizophrenia rather than medication. So in the UK, at least, there is some interest. One of the issues is that the well-established researchers, the people that get funding, and the well-established researchers are very much embedded ideologically, if not financially, in the current system, which is very pro-drug. And so it's a little bit hard as a non-establishment researcher to get research funding, but that's what we're trying to do all the time.
Okay.
It's exhausting.
Yeah, I'm sure. Okay, well, Mark, I could talk to you for another hour or many, I'm sure, but I'm noticing the time. So I think we're going to go ahead and close, and I'm sure we'll have you back either for more interviews or to be panelist again, if you're willing. And we're so grateful to you for always saying yes when you're invited to talk about these issues. So thank you for coming today. Thank you, everybody in the audience, for joining us for the 4th of many more interviews to come from Medicating Normal. If you haven't seen the movie yet, please check our website out at medicatingnormal.com/watch. There you'll find a list of our upcoming community screenings, and we add more all the time and update that list frequently, so make sure you check it often. Our next interview here live on Facebook will be November 16th at 2 p.m. Eastern with Mark Larson. He is an attorney who is the director of the Mental Health Litigation Division in the state of Massachusetts. That conversation will revolve around the intersection of mental health and the criminal justice system. The film Medicating Normal releases new videos on our YouTube channel every Friday at noon Central US time. And we'll be having more live interviews here on Facebook Live every other week or so. We have many exciting people lined up, so stay tuned and tune in. If you have any suggestions for who you'd like to have as a guest, please leave your ideas in the comments section below. You can see upcoming virtual screenings and the schedule for interviews by clicking on the events tab on our Facebook page, Medicating Normal. Lastly, again, we have a store that is selling t-shirts for the next 5 days. We need to sell about 25 more to get to our goal. So if you can help us with that, please go to medicatingnormal.com/store to get one or many. They ship only in the United States currently. So thanks everybody for joining us today. And thank you again, Mark, for spending the last hour with me. It's been a pleasure. Keep in touch, and I'm sure we'll talk to you soon. Okay.
Thanks very much. Thanks for
Bye,
having me.
everybody. Take care.